Hi there, I'd like to present a short video abstract of our narrative review looking at ultrasonography and surveillance for hepatocellular carcinoma in patients with non-alcoholic fatty liver disease. So NAFLD is the fastest growing cause of HCC in liver transplant candidates, and case series from the UK and the US have identified that between 38 and 59% of cases of HCC may be attributable to NAFLD. But this presents a problem for the use of ultrasound scan surveillance. As the original randomized controlled trial for surveillance with ultrasound scan was performed in China in patients with hepatitis B and other types of chronic hepatitis. And this population differs significantly, particularly to the Western surveillance population today. And this presents problems because ultrasound scan sensitivity for the detection of HCC is impaired significantly by central obesity. And we know that over 40% of individuals in the West are now living with obesity, and it's also impaired by steatosis and cirrhosis. And meta-analysis data has suggested that over 30% of detected HCCs were diagnosed beyond the early stage, which obviously impairs the use of this tool in this setting. Now, there are a number of emerging surveillance tools, which include biomarkers, which have been used for both risk stratification of patients at the highest risk of HCC and for detection of HCC. There's been some interest in two-phase low-dose CT scans to try and improve cost, and also in an abbreviated MRI, and this includes non-contrast MRI, which is shown to have similar cost to ultrasound scan and be significantly more sensitive. So to give you an idea of the problem, these are some examples of a case of a patient who has central obesity. And as you can see in figure 1A, this is a longitudinal section of an ultrasound image showing significant acoustic shadowing obscuring the liver and any focal lesions that might be present. However, the patient had a raised AFP, so they went on to have an MRI scan, as you can see in figure B, which demonstrates here a 17mm focal lesion showing portal venous phase washout. And this was confirmed on a CT scan, although again, very poorly defined low density lesion with a subtle increase in vascularity identified at the staging CT. So this patient would not have had their lesion detected if ultrasound alone was used. And then just to contrast, this is a radiological image showing high ultrasound image quality in a lean patient. And here you can see a well-defined 3cm hypoechoic liver lesion, also confirmed at MRI. So we have designed a pragmatic HCC surveillance pathway that we suggest be used for patients with NAFLD that we use in our centre. So first of all, we consider whether the patient is fit for potentially curative treatment of HCC. And then if a patient has a NAFLD and advanced liver fibrosis determined by combining at least 2 non-invasive tests, as per the American Gastroenterology Association guidelines, or cirrhosis, we move to a 6-monthly ultrasound plus or minus AFP. It has been essential that the radiographer comments on the ultrasound scan adequacy to detect HCC, so considering beam attenuation, parenchymal heterogeneity, and visualization of the entire liver. And this is explained in more detail in box 1. The radiographer then makes an assessment of whether the ultrasound scan is satisfactory, in which case 6-monthly ultrasound scan repeats itself, or suboptimal. If a patient has a suboptimal ultrasound scan, we suggest that you then perform surveillance with an abbreviated MRI scan, although the optimal timing of this is yet to be determined by ongoing trials. And if a patient is not suitable for an MRI scan, that the physician should discuss with their local radiology team regarding the timings of a CT scan on a case-by-case basis. Thank you very much.